So from the world of absorption, we are now into the world of inflammation. So now we are into a completely different zone. I told you, on the zones as far as medical gastroenterology are concerned, the one absorption. Now we're going into this very evergreen zone, as one would put it. I think ever since the original medical entrance exams in the country, always at all times, whatever be the pattern, whether it be one-liners or clinical or whether it be NEET or INI, everybody knows at all points that whether it's patho, whether it's medicine, IBD is so important. There's nothing that's not important on IBD. You need to know IBD head to foot. Very systematically, you need to be knowing. It's very easy to study. It's about putting everything on paper. As a medical student, I had lots of doubts on IBD. I was always thinking about so many questions were unanswered at that point, and I was like constantly began to PhDs to find answers to these questions. One question I always had is why is IBD so important? I've never understood still why is IBD so important. As people study, IBD is very rare in Asian patients. It's very less in Indian patients. Very less in most of these Asian countries. It's mostly a disease of the West. It's a different kind of disease. It's much more common there. Not that I'm saying IBD is not here. We still do have a lot of students who are on follow-up for IBD. We do have, but still what I'm saying is it is comparatively less. But the importance that you attach to the topic is huge among us. People talk about IBD length and breadth as far as the entrance is concerned. Everyone who teaches for the entrance will know that okay, IBD is important. Everyone who studies for the entrance will know that IBD is important. But still, we don't see. And most of the time during our MBBS, I told you like on our learning process, those days, it's a case-oriented learning process. Whatever we see, we read. Whatever we see, we read. That kind of process. So I was always thinking, why we're not seeing any IBD? I mean, during my entire MBBS, I have seen only 2 patients with IBD, and those were not in RD. We've actually gone and seen those 2 patients. So no idea basically about IBD. But still, we're thinking it's very important. That's a big doubt I had. Another doubt I was having is why are we comparing ulcerative colitis and Crohn's disease? That's again pretty interesting because you come to the disease proper, then you will again understand it. One is in the rectum, another is in the ileum. Ulcerative colitis is a disease which predominantly involves the rectum. Crohn's is a disease that predominantly involves the ileum. So why are we comparing this again? I had a lot of doubts. So all those doubts I've been having, and let's try to see if we can answer those doubts through this discussion. And coming to a very, very core important topic. I don't think I have to again and again keep emphasizing on the importance of IBD. As far as the entrance student is concerned, he has to have only 2 priorities for learning IBD. The other things I told you are my core issues. Obviously, try to answer. The 2 main priorities are systematically writing down the points in IBD head to foot and then studying it properly so that you don't miss out on anything. That means anatomy has to be clear, physio has to be clear, patho very important has to be clear, medicine has to be clear, radiology has to be clear, pediatrics has to be clear. So all these subjects are being actually brought together in this discussion, and I'm discussing IBD proper. I try to discuss everything because my issue while studying for the entrance with respect to IBD was that I had to go to different books and different chapters to actually get a know-how of this because a lot of things were in patho, few things were in medicine, so few things were in surgery. So it's like having issues. So here we try to discuss it head to foot. So please study systematically head to foot. That's all what I expected from you. The second is clinical analysis. Clinical analysis are only hardly 1 or 2, which we'll discuss alongside with the clinical pictures, and that's going to be very easy. So essentially, very important to have a head to foot understanding. Once again, like the other topics in gastrology, very easy, no complex concepts or anything involved. So just trying to study things as it is. And if you just discuss from head to foot, it is going to be boring. So let's just try to make it as interesting as possible. Okay, and we'll see. So what is this inflammatory bowel disease? Inflammatory bowel disease. If you ask a non-medical person to just tell me what is inflammatory bowel disease, then he'll tell you that there is inflammation in the bowel. But is it that? Let's try to expand on it. So of course, the core aspect here is inflammation, and we are going to talk about this inflammation in a big way. Inflammation in a big way. When I say bowel, again, I would probably put it as colon, but again, small intestine, parts of the small intestine are also getting involved in this. So there is inflammation, but it's much more than that. So that's what we will come to today when we use the term IBD. We are actually speaking, bringing into consideration only 2 diseases. One disease is Crohn's disease, and the other disease is ulcerative colitis. So actually speaking, when I say IBD, I mean only Crohn's disease and ulcerative colitis. There's nothing else that I would actually like to discuss on this. But a few years ago, that's important for us, that we'll come to. A few years ago, when we talked about the term called IBD, we had 2 more entities: microscopic colitis and diversion colitis. Microscopic colitis and diversion colitis were included under IBD. But today, when we say IBD, we include only ulcerative colitis and Crohn's disease. Now, a few years ago, we had microscopic colitis and diversion colitis. Why is it important for us? Yes, it is important for us because there are a few MCQs, solid MCQs that we get from here. Microscopic colitis is a disease whose etiology is something which we are not very clear. We are not very clear about what it is. Long-term NSAID use, long-term PPI use are 2 things that have been linked to microscopic colitis. So long-term NSAID use and long-term PPI use have been linked to microscopic colitis. That's again another exam question. Now, what is this microscopic colitis? We had people who presented with large volume watery diarrhea. So they presented with large volume watery diarrhea. And when you see large volume watery diarrhea, and that too non-ready, chronic large volume watery diarrhea. So it's almost like looking like a small intestinal pattern, right? So chronic non-ready large volume watery diarrhea. So they were presenting for a long time with this. When you look at them clinically they were full normal, okay? And if you check for the endoscopy was also normal. So clinically also normal, endoscopy also normal. This is what we actually call as microscopic colitis. That means large volume watery diarrhea, the patient is presenting clinically normal, endoscopically normal. Exact cause we don't know. It's linked to NSAID, it's linked to PPI. We are not sure about that. But once we did biopsy, okay, in these patients, we got 2 patterns, and that is what is very important for the exam. The 2 patterns that you got when you did biopsy for these patients is a few patients we had a collagen band. Okay, we had a collagen band beneath the mucosa and the epithelium. We had a collagen band. This collagen band is the reason why this is called as collagenous colitis. So we had a collagen band, so that is the reason why this is called as collagenous colitis. And the other patients had intraepithelial lymphocytes. So these patients had intraepithelial lymphocytes. And those patients who had intraepithelial lymphocytes is basically what we call as lymphocyte colitis. So out of this microscopic colitis, we were able to identify 2 set of patients. One patient who had this collagenous band, which is epithelial and subepithelial collagen band. Then we had a few patients who have this intraepithelial lymphocytes. They were called lymphocyte colitis. Now, core entrance point that you have to understand is whenever I think of collagenous colitis is very often linked to autoimmune disorders. And the most important autoimmune disorder I think of when I think of collagenous colitis for my exam is Sjogren's syndrome. There are so many things about Sjogren, I want to bring it here again. But like Sjogren is head to foot very important to watch Sjogren in detail. But in the GIT, extremely important to keep in mind this autoimmune association that is collagenous colitis. And collagenous colitis has an autoimmune association very important in Sjogren. And whenever you think of lymphocytic colitis, you think of celiac disease. If you remember in the associations of celiac, and I've been talking like most common association of diabetes, then the association head to foot. I've been discussing in that we have mentioned this microscopic colitis in the table you can see. In the microscopic colitis, the type that you see here is called lymphocytic colitis. So what I want you to remember here is that microscopic colitis is now not included in IBD1. Second, it is linked to non-term NSAID and PPI use 2. Somebody taking PPI, please stop. Okay, so many issues with PPI will come to that. Number 3 is clinically endoscopically everything patient is normal. Number 4 is patient has a chronic non-ready watery diarrhea. That's not been asked. And biopsy has 2 patterns. Celiac has lymphocytic pattern. Sjogren has collagenous pattern. That's it. So this is what you have to be knowing about microscopic colitis. Diversion colitis is the colitis that you get in the colostomy bag. So after surgery, there are many people who undergo surgery for different causes, including malignancy. You have a colostomy bag, and the colitis that you get on a colostomy bag is what we call as diversion colitis. So diversion colitis is on the colostomy bag. Right now, microscopic colitis and diversion colitis are not included under our disease entity called as inflammatory bowel disease. So right now, for inflammatory bowel disease, there are only 2 examples. One is ulcerative colitis, and the other one is Crohn's disease. And you can actually see all the literature here just to again show you some of the diagrams. Collagenous colitis, can you see collagen band, and lymphocytic colitis, you see the complete lymphocytes. Normal colonic mucosa means normal colonic mucosa. How does it look like? Some small intestinal mucosa has a lot of villi. Here you don't have villi. So we are basically going to talk about the crypts only. Yes, we're going to talk about the crypts only. And we have the epithelium. As usual, we have the mucosa epithelium, the lamina propria, and the muscularis mucosa. They constitute the epithelial layer, the mucosal layer. Then we have the submucosa, and then we have the muscularis propria, where again we have the longitudinal and circular fibers, and then we have the cells. So that's essentially what our understanding is, and we have actually made this very clear also so many times. So we have the 3 layers of the intestinal mucosa. That is the mucosal epithelial cell with the crypts. Then we have the lamina propria. Then we have the muscularis mucosa. Then we have the submucosa. After the submucosa, we have the muscularis propria and serosa. So essentially, the kingmaker here, about whom we're going to be talking a lot, is the crypt, because crypt is going to be of great importance. And the crypts do contain a lot of microvilli. And very importantly, water absorption is a big part here, very, very big part. Because if you look at the amount of water being presented to the intestine, as it is around 9 to 11 liters, and finally, stool water content I told you is less than 200 ml, it's more than 200 ml called diarrhea. So much of absorption has to happen. Then of course we have the goblet cells, secretory mucus, and all that is there again, which we will be seeing in parts. So when I'm saying colitis, I'm actually talking about the large intestine. This is not just the large intestine, as we'll come to. So practically, when you start discussing about IBD, we have two disease considerations. One is ulcerative colitis, and second is Crohn's disease. So it's a comparison that we'll be trying to do at each point, because it's a comparison that's going to fetch you marks for the exam. Now, before we actually get into the disease proper, let me tell you one very, very important point. It's been asked so many times for the exam. Behçet's disease can have GI manifestations which are exactly like that of Crohn's disease. So whenever you think of Crohn's, please think of Behçet. So that's a very important disease that you have to remember. And when we study Behçet again in rheumatology, we mention about that. So Behçet is one disease that can have GI manifestations like that of Crohn's disease. That's because Behçet and Crohn share an antibody, which we'll again see. That's called ASCA antibody. Okay, anti-Saccharomyces cerevisiae antibody. So it's a very, very important disease consideration. Anti-Saccharomyces cerevisiae antibody is being shared by both Behçet and Crohn's. That's why Behçet can have a picture, which is very, very similar to Crohn's. Another point that you have to mention is alpha-methyl dopa. Alpha-methyl dopa is a drug which is used for so many things, especially in pregnancy and all that. But we don't use it long term. We use it long term. But long-term use of alpha-methyl dopa can produce a clinical picture which is very similar to ulcerative colitis. So long-term use can actually produce a clinical picture which is very similar to ulcerative colitis. The third major point you have to be knowing is Campylobacter jejuni. Campylobacter jejuni infections. Campylobacter jejuni generally produces large bowel infections. Large bowel diarrhea is what it produces. Campylobacter jejuni is actually speaking considered to be a risk factor for IBD. So it's considered to be a risk factor for IBD. So Campylobacter jejuni infections have been associated with a lot of things. We're talking about Guillain-Barré syndrome with Campylobacter jejuni. Again, these few associations of Campylobacter jejuni, but it is now considered to be a proven risk factor for IBD. So alpha-methyl dopa can produce a clinical picture similar to ulcerative colitis. Campylobacter jejuni infections are a risk factor for IBD, and Behçet's disease can produce a clinical picture which is very similar to Crohn's of the JJ. So these three opening points are very important. Let us go into detailed discussion step by step, one by one. So what happens in ulcerative colitis? So we're going to start off with the epidemiology of ulcerative colitis. Epidemiology, the genetics, then the pathogenesis. So when you look into the epidemiology of ulcerative colitis, epidemiology of inflammatory bowel disease on the whole, what is most striking for me is the fact that you can see this Jewish, non-Jewish, African Americans, Hispanics, Asians, which means that these two diseases are actually speaking very rare. So that's the first thing that you have to understand. Even if you ask the gastroenterologist how many cases of IBD will be under his follow-up, its numbers are going to be less. So rare. But even though I say that we do have a lot of students who are under follow-up for UCP for Crohn's, etc., so it's not like that's rare, but still on the whole you take it's rare. And especially you can say that it's rare in Asian population, rare in Indian population. That's what I mean. It's most commonly seen in the Jewish population. So that's the first thing. That's just understanding. It's not an MCQ. The first real MCQ that you have to be knowing from here is between ulcerative colitis and Crohn's disease, which is more common. Now, for a long period of time, we were under the impression that ulcerative colitis is a much more common disease. Crohn's is a much rarer disease. But as you would be knowing, so many of the Crohn's disease that so many of the cases of TB that we did diagnose in the 1980s, 90s, etc., we're actually speaking Crohn's, because Crohn's and TB both involve ileum. Whatever we thought as Crohn's, whatever we thought as TB yesterday, it's actually Crohn's today. So we are now diagnosing a large number of patients with Crohn's because we're having much more better investigations, as we shall see, enterography and all that, because we were able to diagnose Crohn's. So on that note, please remember that right now it is Crohn's disease that is more common than ulcerative colitis. So previously it was the other way around. Now it is Crohn's disease that is more common than ulcerative colitis. IBD on the whole is actually speaking more common in males than females. Okay, IBD on the whole is more common in males than females. Crohn's disease is more common than ulcerative colitis. But always keep in mind that if you specifically ask about Crohn's disease, Crohn's disease is more common in females than males. IBD on the whole is more common in males than females. But Crohn's disease is actually speaking more common in females than males. It's also recent. Class 4 phase is what we see is when we're seeing this. That is because of a very important point, and that is your MCQ question. That's because Crohn's disease has been now linked to OCP usage. So the first real MCQ question that I'm discussing from here, apart from the Behçet and Campylobacter jejuni part, is Crohn's disease and OCP usage. So Crohn's disease has been linked to OCP use. Very, very important question. Ulcerative colitis has basically got nothing to do with OCP, but Crohn's disease is linked to OCP. That's why Crohn's disease is more common in females than males. Okay, when you get these diseases, now if you look at the textbook will tell you that there are two peaks for both Crohn's disease and ulcerative colitis. 15 to 30 years is one peak. 70 to 90 years is another peak. Although they write this in the textbook, practically I have not seen anyone at 70 to 90 years coming with ulcerative colitis or Crohn's. For all practical purposes, ulcerative colitis and Crohn's generally start off somewhere between 15 to 30 years, and generally it is your first year, second year MBBS student who gets diagnosed with ulcerative colitis or Crohn's disease, and then they start living with the disease. It's a different thing altogether, which you will see. So the origin of the disease is somewhere around 20 years. You can't think of this as a ED for somebody who's presenting with these kind of symptoms at 30, 35, 40, never. Even 30 years to have the first symptom is rare. Textbook says 15 to 30 years, but always keep in mind that the patient is going to be in and around 20 years. That's a very important thing. And textbook will say 2 peaks, but in reality we are not actually seeing 2 peaks. Next major question that you get is smoking. This is a very, very, very important question, because there are only few conditions in medicine where smoking is actually speaking protective. And one such very important condition is ulcerative colitis, where smoking is protective, and Crohn's disease where smoking is causative. So causative in terms of Crohn's disease and protective in terms of ulcerative colitis. Always keep in mind OCP and smoking are two questions that they keep on asking left and right. OCP is linked to Crohn's, not linked to ulcerative colitis. Smoking is causative in Crohn's, smoking is protective in ulcerative colitis. Same way they can also ask another question, which is appendectomy, because these two things are often clubbed together. Appendectomy and smoking are the two things which are protective in UC. Appendectomy and smoking are protective in UC. Crohn's disease has nothing to do with appendectomy, and smoking is causative in Crohn's. So smoking is causative in Crohn's, and smoking has appendectomy has nothing to do with Crohn's. So please keep in mind all these things. Then with respect to familial inheritance, these are two conditions where there is significant familial inheritance, significant familial concordance, as I can actually say, and concordance is more for Crohn's disease. So concordance is more for Crohn's. Right, although it's there for both ulcerative colitis as well as Crohn's disease, concordance is actually more for Crohn's. And final statement I think will be the most important statement that I actually want to make, and that statement is antibiotics in the first 1 year of life. Antibiotics in the first 1 year of life can be really bad, and that can actually increase the risk of both Crohn's and ulcerative colitis, or rather I can say increase the risk of IBD by 3 times. That will alter the flora of the GI, as we shall see. So that's one reason, or main reason why we are not using antibiotics, because it increases the risk of IBD. So these are the opening statements on the epidemiology of IBD. On the whole, Crohn's disease is more common than ulcerative colitis. 15 to 30 years is when you are actually seeing the disease. Second week is there in the textbook. Males more than females is applicable for IBD on the whole. But if you see Crohn's disease specifically, it's females. Smoking and appendectomy are protective. In the case of ulcerative colitis, very, very important. OCP is being linked to Crohn's disease. Familial pattern is seen in both conditions, but more common in Crohn's disease than ulcerative colitis. Alpha-methyl dopa can produce a clinical picture which is similar to ulcerative colitis. Okay, so this is very important. This is the same table that I've been trying to discuss. Again, to tell you the smoking, OCP, appendectomy, all these things. So from the epidemiology part, we go to the genetic syndromes associated with IBD. It's again very important for the exam. One-liner questions, catchy questions you get for the exam. Now, as far as genetic syndromes associated with IBD are concerned, single most important one is Turner syndrome. So in Turner syndrome patients, you get a lot of IBD. You get ulcerative colitis also in Turner syndrome patients. Few Turner syndrome patients you can see having Crohn's disease. So both are associated. So one most important single syndrome that you want to remember is Turner syndrome. Then comes three more syndromes. Three more syndromes that you have to remember are one, VAS, which is Viscott-Albrecht syndrome, which again you would have studied in so many places. I myself have taught you in so many places. Second is glycogen storage disease type 1, what we call as the famous von Jurke disease. And then Hermansky Hermansky Pudlak syndrome. So Hermansky Pudlak syndrome. These are three very, very important genetic disorders which are associated with diabetes. Viscodilate syndrome, glycogen disease type 1 conjugate disease, and Hermansky Pudlak syndrome. Now, what I want you to be very clear is that in viscodilate syndrome, it is a non-granulomatous involvement. Okay, non-granulomatous involvement. Whereas in GST type 1 and Hermansky Pudlak, you are having granulomatous involvement. So granulomatous involvement here, and there you are having non-granulomatous involvement. What does it actually tell you? Crohn's disease we will study in histopathology is classically associated with granuloma, whereas ulcerative colitis is generally not associated with granuloma. So what does that tell us? That viscodilate can produce a picture which is very similar to ulcerative colitis because it is non-granulomatous. Hermansky Pudlak in GST type 1 will produce a picture which is similar to Crohn's disease because it is granulomatous. That's the only thing here. Now, these two topics are very important. Otherwise, you have to be knowing the other manifestations of this also, which you will have to study from the respective places. But please don't forget, viscodilate syndrome is characterized by the triad of recurrent eczema, skin infections, eczema, then recurrent thrombocytopenia. Yes, recurrent eczema, recurrent thrombocytopenia, recurrent sinopulmonary infection. So, very important. Eczema is there, sinopulmonary infections is there, and we have thrombocytopenia. This is the triad of viscodilate syndrome. It is an X-linked condition. Yes, X-linked condition. This is what we have to see. And always keep in mind, in viscodilate syndrome, we are having microplatelets. You are having small sized platelets in viscodilate syndrome. So, small sized platelets, thrombocytopenia, sinopulmonary infection, and eczema. This is in general. But the more points, please study from patho. Hermansky Pudlak disease is an autosomal recessive disease. Viscodilate is an X-linked disease. It's an autosomal recessive disease. Hermansky Pudlak is actually characterized by three things. One is pulmonary fibrosis. ILD is there in Hermansky Pudlak. Albinism is there in Hermansky Pudlak, and platelet functional disorder. Okay, so platelet functional disorder. So you are having platelet functional disorder, not platelet number issue. Platelet functional disorder. We have albinism. Yes, albinism, and we have pulmonary fibrosis. So we again taught you in pediatrics. Very important disease condition that is Hermansky Pudlak. Then glycogen storage disease type 1 or conjugate disease. I don't have to tell you. You have studied enough and more in your biochemistry. So many things can come from there. Hypoglycemia with or without seizures, very commonly asked. We get hypoglycemia with the characteristic tall fishes. We have hyperlipidemia. We have lactic acidosis. So we have again this colitis involvement. All those things are actually seen. So epidemic is there, hyperuricemia is there, lactic acidosis is there, hypoglycemia is there. So many manifestations of conjugate disease, and that is glycogen storage disease due to deficiency of the enzyme called glucose 6 phosphatase. Okay, so those are the three conditions. Now I think that's very clear. Now apart from these three, there are two very important things that you have to remember right at the end of this table, and those two are extremely, extremely important. And out of that, the first one is what we call IPEX syndrome. So IPEX syndrome is a very common exam question, very, very common exam question. Even in 2020, this was asked. What is the meaning of IPEX syndrome? IPEX syndrome is immune polyendocrinopathy X-linked. Okay, immune polyendocrinopathy X-linked. Now this immune polyendocrinopathy X-linked is actually characterized by a triad. The triad is equal to dermatitis, okay, type 1 DM, or sometimes thyroiditis. Okay, type 1 DM or sometimes thyroiditis with ulcerative colitis like enteropathy. So ulcerative colitis like enteropathy, type 1 DM or thyroiditis, and dermatitis. This is the triad of IPEX. Now what is this IPEX due to? Means IPEX is due to loss of T regulatory cell function, or what we call Treg function. T regulatory cells are the cells which actually help us in tolerance, or tolerance is basically due to T regulatory cell function, which again study in immunology in detail. Tregs are cells, like for example, I'm getting a graft, I'm having CKD, you are giving me your kidney, and I'm getting the graft, and another person is having CKD, is getting a graft from someone else. How do you know which kidney is going to survive more? If you're related, then you can say based on that, but you're taking unrelated graft. Unrelated graft, how can you predict? That can be predicted by my Treg levels, my basic Treg levels. Tregs are a subset of my CD4 lymphocytes. So if you check my Treg levels and my Treg levels are high, that means that I'm likely to have a tolerance to the graft. And suppose I am actually having low Treg levels, in the long run I will definitely lose the graft. That's why Tregs are extremely important with respect to tolerance. So Treg number has to be always high. But this is something that we can do. No, Tregs genetically mediated. It's like some people have higher Treg levels, some people have lower Treg levels. That's it. So what are these Tregs? You see, CD3 is the pan T cell marker. CD4 is the CD4 helper T cell. Inside that few cells which are having the CD25, they are called as your Tregs. So CD3, CD4, CD25. That is a property that we study in patho. But here, what I want to highlight most is these Treg cells have a transcription factor. The transcription factor for Treg cells is what we call as FOXP3. Very important, very important, very, very important. This loss of FOXP3 transcription factor is the one that leads to what we call as IPEX syndrome. So IPEX syndrome is due to loss of FOXP3. It is characterized by a triad of ulcerative colitis like illness with dermatitis and endocrine illness. Endocrine illness is mostly type 1 here. This has been asked again and again. Okay, now which is the most important powerful anti-inflammatory cytokine in the human body? Almost everybody knows. Now, interleukin 10 is like a very powerful anti-inflammatory cytokine. Now suppose you are having deficient interleukin 10, or interleukin 10 receptor function. So deficient interleukin 10 or interleukin 10 receptor function, that can lead to refractory IBD in childhood. Very, very important. When you get IBD in childhood, two things you have to be very clear with. Either it can be part of IPEX syndrome. Refractory IBD in childhood is very often linked to interleukin 10 defect or interleukin 10 receptor defect. Interleukin 10 is a very potent powerful anti-inflammatory cytokine. So this table is full of MCQs, full of MCQs. Please study Turner's, please study those three syndromes, and then always keep in mind IPEX syndrome due to loss of FOXP3 and the triad of IPEX syndrome, interleukin 10 defect producing early refractory childhood IBD. Again asked so many times for exam. So in this opening module, we have tried to look into mostly just the introductory points, but two very, very important points. Just tell you the triad of IPEX, entropathy, endocrinopathy, dermatitis, and this FOXP3 mutation, which means that you're not having Tregs. Okay, so nothing much can be done for this. Just about like a supportive care, and now people are trying gene therapy and all that. That's beyond the scope of our discussion. So in this opening module, it's all about looking into the genetics as well as looking into the genetic syndromes and the epidemiology of IBD. From the next module, we'll start going into the etiopathogenesis, the pathology, and of course a lot more on these two very important diseases, that is UC and Crohn's disease. Why do we get IBD? This is a question great international scientists have been asking worldwide and still not been able to find out an answer. So we actually don't know much about this disease. Let me make this very, very clear. Etiopathogenesis is still not clear as such. So whatever we know, we will discuss with respect to the entrance. So what is responsible for IBD? If you ask me, I can tell you in one word that there is a dysregulated mucosal immune response. So there is a dysregulated mucosal immune response in somebody who is genetically susceptible. So dysregulated mucosal immune response in a genetically susceptible individual is responsible for IBD. So there is some dysregulation in the immune response in somebody who is genetically susceptible. So what is this genetic susceptibility? You can ask me. There's familial components I told you, but what is the genetic susceptibility? Genetic susceptibility in ulcerative colitis has not been studied. We really don't know what is genetic susceptibility there. But in Crohn's disease, we have been able to study. That is called as NOT2 gene polymorphisms. Very, very important. NOT2 gene polymorphisms have been studied here. NOT2 is also called as CARD15. Okay, it is either called as NOT2 gene or called as CARD15. So NOT2 gene or CARD15 polymorphisms. So many polymorphisms are there. They are actually linked to this, and they are on chromosome 16. So on chromosome 16. So this is what we mean by a genetically susceptible individual. HLA are not being strikingly associated. So we can't actually study that, or we can't say that this HLA is associated. That way we can't say. So there is a dysregulated mucosal immune response that is happening. Again, let me tell you what is this dysregulated mucosal immune response has been studied to an extent in Crohn's disease, but again not studied in detail in ulcerative colitis. So understanding of ulcerative colitis is very, very, very primitive. Crohn's we've been able to actually get a bit more know. What is that bit more know that we got? That in Crohn's, this dysregulated mucosal immune response means that there is a defective innate immune system. So there is defective innate immunity. You'll study that again in your pathology classes. Innate immunity, which is so important. And I also mentioned that in few places in the So there is a defect in your innate immunity. So when I say defect in your innate immune system, what are the three aspects of the defect in innate immune system? There is decreased clearance of intracellular microbes. So there is decreased decreased clearance of intracellular microbes. That's very, very important. These intracellular microbes are not being actually cleared. Intracellular organisms are not being cleared. Very, very important organism which is not being cleared is your Mycobacterium paratuberculosis. So Mycobacterium paratuberculosis, Mycobacterium avium intracellular. Two organisms are not here. Again and again, ask for your exam. What is the organism linked to this, etc. This is not causative or anything. It's just that there is decreased clearance. Second is that there is decreased production of defense cells from the parent cells. I told you about parent cells, okay, in the opening few slides with respect to the intestinal anatomy. So decreased production of defense cells from the parent cells. So many defense cells and other important phospholipids have been produced from the parent cells. So decreased production of defense cells from the parent cells. Then of course we have defective cell clearance is another way linked to defective autophagy. So defective autophagy, what is autophagy? Also will come to later on. So decreased production of defense cells from the parent cells, defective autophagy, defective clearance of intracellular organs, especially Mycobacterium paratuberculosis, Mycobacterium avium intracellular. These are the three aspects of a defective innate immunity. So what actually happens is defective innate immunity. This is studied in Crohn's. Again, I'm telling you, ulcerative colitis, we don't have much idea about this. What I'm saying is more applicable for Crohn's. As a result of this defective innate immune system and this organism not being clear, we are having an overactive adaptive immune system. So adaptive immune system becomes overactive in the setting of a defective innate immune system. So that is the major thing. So if somebody is asking you what is happening in Crohn's, you can say that in somebody who is having not two gene polymorphisms or genetically susceptible individual, there is a dysregulation of the mucosal immune response such that the innate immune system is now not working properly. That is leading on to decreased clearance of organisms, defective autophagy, defective defense and all that. And there is an overactive adaptive immune system. Overactive adaptive immune system can be along the Th1 lineage, it can be along the Th2 lineage. There is Th1, Th2, Th7, all that in studying immunology. And you'll be taught in immunology class, and I also discussed that with respect to rheumatology diseases. Th1 lineage gets overactive in Crohn's disease, Th2 lineage gets overactive in ulcerative colitis. So it's the Th2 lineage that gets overactive in ulcerative colitis, Th1 lineage that gets overactive in Crohn's. So this is what we actually know. This is all what we actually know. We also know that there is a bit of a change in the gut flora. That means Faecalibacterium, which is a very protective organism which you normally see in the gut flora, is now not seen in these patients, especially Crohn's patients. So this is what we actually know, and this is what has come for the exam. Nothing more we know, so there's still lots more to explore. In spite of following up these diseases for more than 50 years or 60 years, still we have not been able to conclusively say as to what is what, etc. And there are no therapeutic points also here. Can you identify a therapeutic point of the representatives? No. So that means that our understanding is very limited. Okay, and that is all what we have to study from here and the questions. Exogenous and endogenous factors together lead to a dysregulated mucosal immune response with adaptive overactivity and the innate immune system not working. Genetically susceptible is the reason why this keeps on getting asked for the exam. This is correct. Mycobacterium paratuberculosis is also been asked for the exam. There is defective clearance of intracellular organism. This is the organism. So many of these names are all there, but none of this is possible to study. Only thing that we have to remember from here is your not to. And what are the factors which can add on? What are the factors which can add on or can be probably considered as risk factors? Are one, antibiotic use, which we have already seen, which is linked to childhood IBD. Yes. Second is NSAIDs and smoking. Again, has been linked to IBD, especially elderly. They say, the second big case that we're talking about. We're not seeing so much in India. And ever so very important, NSAIDs and smoking linked to IBD is mostly equal to a Crohn's disease. Yes, mostly linked to a Crohn's disease. And now we say all these stress, diet, all these things are related, but or we talk about all that finally when we don't know anything. Yes. Interleukin 10 receptor defect has been associated with early onset refractory childhood IBD. Not the polymorphisms are chromosome 16. Defective autophagy is seen in Crohn's disease. Th1 response is seen in Crohn's disease. Th2 response is seen in ulcerative colitis. Okay. So equivalence part is actually speaking very easy. Why is it very easy? Because we really don't know anything. Because we don't know anything, we are able to actually talk a lot. From the equivalence, we go to a more business end, from where we get lots and lots of questions. That is the gross and microscopy of Crohn's and ulcerative colitis. So we're going into the gross, that is gross pathology and the microscopy of both the diseases. We will start off with ulcerative colitis. So we'll start off with ulcerative colitis. So when I think of ulcerative colitis, okay, first I need to be knowing where is the involvement. Then I need to be knowing what is the involvement and how it happens. Yes. When you think of ulcerative colitis, let's make it very, very, very clear. First and foremost, it's that 50% of patients with ulcerative colitis have involvement of rectum alone. So who is the king here? The king site here, rectum. If you have that in mind, in Crohn's disease here, that is when I think things are very easy. Actually speaking, very easy. So 50% of the patients with ulcerative colitis have involvement of rectum alone. 30 to 40% of the patients have involvement of rectum plus sigmoid. Okay, rectum plus sigmoid. And around 10 to 20% of the patients have involvement of the rectum, sigmoid, and colon. What we call as a pancolitis. Okay, rectum, sigmoid, and colon. So what do you understand? So rectum, then from the rectum, sigmoid, then rectum, sigmoid, and colon. We call it as a pancolitis. And out of these 10 to 20% of this group, 10 to 20% of this group, which means totally 1 to 2%, can have ileum involvement. This ileum involvement is what we call as backwash ileitis. So this is what we call as backwash ileitis. So 10 to 20% of patients with pancolitis can have backwash ileitis. So this I think makes things very easy. Why does it make things very easy? Because you now understand that when you talk of ulcerative colitis, you don't have to think of the stuff. You don't have to think of the small extent. You just have to start from the rectum. It's rectal involvement, then rectum plus your sigmoid involvement, then 10 to 20% have pancolitis, and out of those pancolitis patients, around 10% of them have ileum involvement, which is called backwash ileitis. So basically, the involvement part is very, very clear. Okay. Now let's try to get into the crux. When you try to get into the crux, what kind of an involvement are we talking about? We're going to talk about the pathology, the cross features in ulcerative colitis. Let me tell you very, very importantly, right at the beginning itself, that the involvement is a very superficial involvement. Ulcerative colitis is a disease where we can know the disease at times because the involvement is always superficial. Superficial meaning that it is only the mucosa and the superficial part of the submucosa that is getting involved here. So only the mucosa and the superficial submucosa that is getting involved here. So that's a very, very important reason why we want to consider ulcerative colitis as a much more better disease than Crohn's. Okay, it is superficial. Second thing I want to tell you is that it is a continuous involvement. Yes, this is superficial involvement. This is continuous involvement. I told you, rectum, then rectum, sigmoid, then pancolitis. So it's not like discontinuous. You're having some skip lesion here, there, nothing. This is superficial involvement. This is continuous involvement, and this is symmetrical involvement. So superficial, continuous involvement, and symmetrical involvement. I'm telling you right at the beginning to make it very clear in your system that we are dealing with a disease which, in terms of its nature, is not that malignant. You can consider it to be kind of benign, not fully benign. So many issues with respect to the disease, but still, I'm telling you on a head-to-head comparison basis, on a head-to-head platform, if you compare with CD Crohn's disease, this is a little bit more better. Let us see the pathology features, one by one pathology features. The first change that happens here is that the mucosa will start becoming red. So you're having a erythematous mucosa with a fine granular surface. Okay, so erythematous mucosa with a fine granular surface. It's a very important question because what is the first gross change in ulcerative colitis? Gross pathology change in ulcerative colitis is this erythematous mucosa with a fine granular surface. So even endoscopy, this is the answer. We'll come to endoscopy later on, but gross specimen, if you see what is the first change, mucosa becomes erythematous with a fine granular surface. Then what happens is the mucosa will start having hemorrhage, edema, and ulceration. So hemorrhage, edema, and ulceration of the mucosa is the second change. So first change is erythematous mucosa with a fine granular surface. Then you have hemorrhage, edema, and ulceration of the mucosa. Third thing that actually happens is when you're having this ulceration of the mucosa, there is epithelial regeneration. This regeneration of the epithelium leads to an appearance called as pseudopolyps. Pseudopolyps are actually speaking inflammatory polyps. These inflammatory polyps which are due to epithelial regeneration. So inflammatory polyp due to epithelial regeneration is what we call as a pseudopolyp. So these are the three main changes in ulcerative colitis. So what are the three changes? Erythematous mucosa with a fine granular surface, hemorrhage, edema, and ulceration into the mucosa. Epithelial regeneration producing inflammatory polyps. This epithelial regeneration producing inflammatory polyps is called as pseudopolyps. So these are the three main things. Okay. Now in case you are having a chronic long-standing UC, Okay, nowadays it is not common because you do find it on time and treat. Chronic long-standing UC can actually result in a atrophic featureless colon. Okay, atrophic featureless colon. This atrophic featureless colon, which is basically having loss of ostrations, and you can see that there is shortening of the colon as well as narrowing of the colon. So loss of ostrations, shortening of the colon, and narrowing of the colon is what we call as the famous lead pipe appearance. This is called as the lead pipe appearance. Some books, in olden books, you can see it being called pipe stem. I'm not very happy with that name. It is better to call it as lead pipe appearance. So generally we don't see this. Active disease, what are you looking for? Looking for erythema, looking for the fibrosis, edema, hemorrhage, ulceration, and pseudopolyps. This is all what you're looking for. But chronic long-standing disease can lead to ostration loss in the colon with an atrophic featureless narrow colon. This is called as the lead pipe appearance. And rarely we can have what we study later on called as fulminant colitis. Fulminant colitis is not at all common in UC. In UC, with chronic featureless colon is also not common. Fulminant colitis is also not common. Fulminant colitis may be associated with colonic dilatation. Correct? Colonic dilatation more than 6 cm is what we call as toxic megacolon. And toxic megacolon is very dangerous because it can even lead to perforation, peritonitis, sepsis, and all that. So toxic megacolon is a combination that we expect in fulminant colitis. Lead pipe colon is what we see as part of chronic colitis. But do we see this in reality? No, we don't see. What we see is active disease. Then we treat the active disease goes into remission, and then the patient can have relapses at different points. That is what we normally see. So from here for the exam, 5 points to keep in mind. What are the 5 points? Erythema because of the fine granular surface is the first finding. Second point to keep in mind is hemorrhage, edema, ulceration because of it all is a supervision. Third point is that this can lead to epithelial regeneration, giving rise to classical appearance called pseudopolyp appearance. 4 rarely chronic disease can be there leading to lead pipe appearance. 5 rarely fulminant disease can be there leading to toxic growth. Okay, it can't be more spoon feeding than this, but this topic requires spoon feeding. So wherever spoon feeding is required, you have to do that. And this is that one topic which definitely warrants that. We go to the microscopy now. So before we go to the microscopy, you can actually see, right, ulcerative colitis with this correct endpoint. See, there is no skip lesion, nothing like that. We have a diffuse involvement with broad area of ulceration, and there is nothing like we'll come to cobblestoning, thickening. All that's not there. This is superficial involvement, mucosal involvement, and Crohn's disease will come. Okay, this is the lead pipe sign. Lead pipe sign actually talks about a rigid featureless appearance of the colon, complete loss of hostile markings. You can actually see it is completely lost, and usually some degree of narrowing is also there. If you compare with the colon on this side, then you will understand the colon on this side. It is classically described in various studies. It's not described so much on pathology, but you can see it's even with the pathology. See, this is how a general normal colon pattern will look like. Here, when you see this part, you can see that the hospitations are all being lost. There is some degree of the normal appearance is not seen here. There's some degree of narrowing also. Here you can see it is like significantly narrow. And as you move to this part, you can see that this is better and better. Here it is better, but here it's getting bad. This rigid atrophic featureless colon, which shortening is what we call as lead pipe appearance. Okay, various studies you can actually see better, but these days are we doing all that is a question mark. So gross, these are the findings. Again, when we come to radiology, we'll discuss more. We come to the microscopy of ulcerative colitis. When we talk about the microscopy of ulcerative colitis, what are the key features that have to come to your mind? First thing that has to come to your mind is that this is a superficial involvement. Yes, this is a superficial inflammation. So that has to be the most important point. So there is no deep inflammation as such here. That is also the reason when you look at the bowel, when you study Crohn's, you understand its thickness, right? Here there's not so much of thickness, and because there is a deep involvement, it can penetrate through the serosa and produce what? Fistula, abscess, all that. All that will not be seen here. So it's a superficial involvement. Second is what is seen? Cryptitis. Yes, cryptitis is neutrophilic infiltration of the crypt. You will see cryptitis, but cryptitis is a very non-specific finding. You can get it in so many places. Very important is here there's cryptitis with loss of crypt architecture. Very important, very important, because cryptitis can be seen in so many places, but cryptitis with loss of crypt architecture is seen only in ulcerative colitis. Third point is Paneth cell metaplasia. Yes, again asked so many times. I told you, Paneth cells when we discussed in anatomy, it is going to be a key plan. Paneth cells is generally not seen distal to the hepatic structure. When you see them distal to the hepatic structure, we call it Paneth cell metaplasia. Paneth cell metaplasia is a very important finding of ulcerative colitis. Point number 4 is basal plasma cell and lymphoid aggregates. Okay, basal plasma cell and lymphoid aggregates. Actually speaking, this is the earliest finding. Basal plasma cell and lymphoid aggregate is the earliest finding, and even when the patient is in remission, if you see this under the microscope, it tells you that there can be relapse later. So that level is an important finding, but that has not been asked. These are the 4 findings. So please don't get it wrong. Superficial inflammation, cryptitis with loss of crypt architecture, Paneth cell metaplasia, basal plasma cell and lymphoid aggregate. These are the 4 findings. So I think gross part of UC is very clear. Microscopy of UC is very clear. General idea about UC as a disease also I think is very clear. Now what will you tell me is not seen in UC at this point? I will tell that UC can never have a transmural involvement. It is superficial involvement. UC can never have skip lesions, which means that skipping is not going to be possible. It is continuous involvement. Correct. UC can never have deep pulses because there it was all superficial, right? So it's not going to have deep pulses. UC can never have thickening because thickening is what is not seen in superficial involvement, and because of that, fissure, fistula, stricture, fibrosis, all this is not going to be seen in UC. So fissure, fistula, stricture, fibrosis, abscess, transmural involvement, skip lesion, deep ulcer, all this will be never seen in UC. So you know what is not seen is equally important. You know what is seen, this is what is not seen. Correct. Yes. From here, we are now going into Crohn's disease proper. So this is just to tell you, basal lymphoplasmacytosis, which I told you, crypt atrophy is there, but loss of crypt architecture is the best term. Superficial erosions are what we have to talk about, and disease infections, predominantly neutrophilic infection. Yes, that's it. Now we go to Crohn's. So that's going to be a comparison. So when I told about ulcerative colitis, what did I say? 50% bronchitis, 30 to 40% lactosigmoiditis, then pancreatitis, and then few have backwash. That's what I told you. Here we have 40 to 50% of patients having ileocolitis. So most common manifestation here is a ileocolitis. So once again, who was the kingmaker there? Rectum. Who is the kingmaker here? Ileo. So 40 to 50% have ileocolitis, 30 to 40% have ileitis, 30 to 40% have ileitis, and around 15 to 20% have colitis. So 15 to 20% have colitis. This is the manifestation. So what are the major MCQs that have to come to your mind here? Point number 1 is that Crohn's disease can occur anywhere from the oral cavity to anal canal. So this is just one type of disease which can involve anywhere from the oral cavity to the anal canal. There is absolutely nothing that cannot be involved. That's why we had a question for the exam last year. Perianal involvement is seen. Perianal involvement is seen in Crohn's. Ulcerative colitis cannot involve anywhere else. It is ending at the level of the colon. And 1 to 2% patients in total can have backwash. That's all. Here you can have perianal involvement, you can have stomach involvement, you can have esophagus involvement. Anything is possible. Point number 3 that I want to highlight from here is that there it was a very superficial involvement. Here it is a transmural involvement. Transmural involvement means you are going generally up to the muscularis propria. You are going up to the muscularis propria. Sometimes you can go even up to the serosa, and sometimes you can penetrate the serosa and produce fissure, fistula, stricture, fibrosis, all that. And because it is a transmural involvement, you will definitely have thickening of the bowel. Thickening of the bowel is something we never saw there. Because of that thickening, here you are going to have lots and lots of complications. Again, the stricture, fibrosis, fissure, fistula, all that. And number 5, this is asymmetrical non-continuous involvement. There we are talking about continuous involvement. Here it is asymmetrical non-continuous involvement. That's what we classically call as what lesion? Skip lesion, skip lesion, skip lesion. So these many things have to come to mind. If this is clear, then I think the rest of the things are going to be nuts for you. Okay, so I think that part is very clear. Now, let us go to the gross and microscopy, then again come back. So this is the macroscopy or gross appearance. What is the gross appearance here? So gross appearance, there I told you what is the first point. Superficial, symmetrical, continuous involvement. Here I'm going to say deep, transmural, asymmetric, and skip lesions. So deep, transmural, asymmetric, skip lesions. Clear, very easy. What is the earliest finding? Earliest finding there was erythematous mucosa with the fine granular surface. Earliest finding here are small translucent ulcers that you see, and they are called as after ulcers. Some people even call it as after ulcers. It's not easy to see them, but if somebody's asking you, you see after ulcers. But what is more visible to us? Generally, what is more visible to us are linear or serpentinous ulcers. Okay, linear or serpentinous ulcers. This is what is actually speaking more visible to us. And what these ulcers do is that the ulcers will fuse longitudinally as well as transversely. When they fuse longitudinally and transversely, they will be leaving behind islands of uninvolved mucosa, like one ulcer like this, 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 like this, like this. So what will happen is that they will fuse longitudinally and transversely, and there will be areas of uninvolved mucosa in the middle. Those areas of uninvolved mucosa in the middle is what we call as cobblestone appearance. So just like pseudopolyps there, here you are having cobblestone appearance. So gross features, earliest findings after ulcers, but very hard to make out. What we see normally are linear ulcers or serpentinous ulcers. Then these ulcers will fuse longitudinally and transversely to leave behind areas of uninvolved mucosa. This is called as cobblestone. There we studied pseudopolyp, here we are studying cobblestone. And there we finally got atrophic featureless colon with loss of concentrations, what we call as a lead pipe colon. Here the appearance is called as garden hose appearance. Okay, very, very important. Garden hose appearance. So there it was lead pipe appearance. Here it is called as garden hose appearance. Garden hose appearance is actually equal to extensive fibrosis and stenosis, and it can be seen in small intestine or it can be seen in esophagus also, and especially in association with systemic sclerosis. So what happens here is that you have extensive fibrosis and stenosis. And this garden hose appearance is classically described in your Crohn's disease, but it's also described in systemic sclerosis that we study there. But in Crohn's, the end appearance is what we call as garden hose appearance. So cross-wise, there is absolutely no confusion. You know what is there? Erythematous mucosa, the fine granular surface, hemorrhage, emancipation of the mucosa. Then you are having this pseudopolyp appearance, and finally lead pipe appearance. Here you are having superficial is replaced by deep. It is asymmetrical. It is associated with thickening. There's going to be fissure. There's going to be fistula. There's going to be fibrosis, and this final appearance is what we call as garden hose appearance. And in between, very important to remember that these ulcers can fuse longitudinally and transversely, leaving behind areas of uninvolved mucosa, which is what we call as your cobblestone. So I think all the points are very, very clear. There's nothing better that I can do. I'm generally not a person who will explain like this. I'm a person who give you ideas and then try to build on the ideas. But here that is not what is recommended. I'm equally good at mugging up. But the point is that you do mugging up at the later stage. Indian exam pattern requires you to mug up very effectively, very efficiently. Otherwise, you can never become successful in the Indian pattern examination. So what you have to understand is initially you study the concepts and later mug up. But this chapter from the beginning itself, you have to study systematically. Because mugging up is an art. If you just sit and mug up, you can never score. That's why you see so many students they sit and study for hours, they keep mugging, but they never score anything. Somebody who mugs up very systematically, sequentially, he will be able to score. So thickening of the wall, Crohn's, fissure, fistula, abscess, fibrosis, everything is Crohn's. This is the garden house appearance. Stricture is also Crohn's. And thickening the mesentery can encase the bowel wall. Thickening the mesentery encasing the bowel wall is called creeping fat. Okay, creeping fat appearance. So thickening the mesentery encasing the bowel wall, which we see in Crohn's is called creeping fat. All this will be taught you in pathology once more, but the gross appearance has to be pakka. If you know the gross appearance pakka, both the diseases, everything else you can make out as we discuss subsequently, you understand. Everything else can be made out. Here it is just about knowing that okay, this is superficial, this is symmetrical, continuous, with rectum, rectosigmoid kind of involvement, with no thickening, with no encroachment, with no transmural involvement. That makes it very simple. And here we are, on the other hand, going into asymmetrical discontinuous depletion with kind of transmural involvement, thickening, which can lead on to what is can lead to fibrosis, which can lead to stricture, which can lead to fistula, which can lead to all sort of complications. And ulcerative colitis involves only set areas, whereas Crohn's can involve anywhere from the oral cavity to the anal cavity. Yeah. So lastly, microscopy of Crohn's. How is microscopy of Crohn's going to be different from that of UC? First point, I don't have to even tell you this, that this is going to be transmural, transmural, transmural. Point number two, there are granulomas here. We never talked about granuloma there. We're talking about the famous non-caseating granulomas. These non-caseating granulomas can be seen anywhere. Okay, can be at any point, any level. It can be involved or uninvolved level, intestinal or external. So there's nothing like that. It can be anywhere. And non-caseating granulomas can be seen in so many conditions, right? Sarcoid can have non-caseating granuloma, but the fun part of it is that TB can also have non-caseating granuloma. Gastritis disease can have non-caseating granuloma. Hypersensitivity pneumonitis can have non-caseating granuloma. Berliosis can have non-caseating granuloma. Crohn's can have non-caseating granuloma. So the endless list is endless. But those conditions that I told you are very important for the exam, very important pathology question also. So please do keep it in mind. Then lymph node, yes, lymphadenopathy, very important. Mesenteric lymphadenopathy is there. We are having cryptitis here. Yes, you can get cryptitis here. You can even get a crypt abscess. Yes, crypt abscess is generally not seen in UC. It is seen in Crohn's, but there is no loss of crypt architecture here. Very, very important. So cryptitis with crypt abscess is more in favor of Crohn's. Cryptitis with loss of crypt architecture is seen in UC. Okay, and here instead of panel cell metaplasia, we are having pyloric metaplasia. Yes, there it was panel cell metaplasia. Here it is pyloric metaplasia. Right, and you can see lymphoid aggregates here. Okay, lymphoid aggregates can be there, but basal lymphoid aggregates and plasma cell aggregates are very classical of ulcerative colitis. Can be seen in Crohn's, but it's more important there. So superficial, transmural, no granuloma, granuloma, no lymphadenopathy, lymphadenopathy. Cryptitis with loss of crypt architecture. There, cryptitis with crypt abscess. Here, panel cell metaplasia. There, pyloric metaplasia. Here, basal plasma lymphoid aggregate, more in favor of ulcerative colitis, but some lymphoid aggregates can be seen in Crohn's also. Okay, so once again, if you see the granuloma, there is nothing more that you have to discuss. So in this particular module, once again, transmural involvement with granulomas and fibrosis, and you can see the classical non-caseating granuloma. Okay, so in this module we have tried to look in toto with respect to the pathogenesis of the disease, understood what the disease is, what it stands for, where it involves, and what you expect. So you expect certain things in UC, right? You expect what? You expect inflammation, then you expect a resolution because it is superficial, and then you know that in permanent cases that can be recorded, long-standing cases can lead to leg appearance, all that you know. But essentially when you talk about the disease, it's going to be superficial. Whereas in Crohn's, it's going to be transmural, it's going to be deep, it's going to be non-continuous, asymmetrical stipulations with all kinds of complications, including fissures and fistulas and strictures and fibrosis and all that. So this is the basic makeup of these two very important diseases, and from here we'll be going into the clinical features diagnosis and the management part. Thank you.